Let's go ahead and get started. Well, thank you all for joining us today. My name is Danielle Rankley. I'm a program coordinator with the UMTRC, or the Upper Midwest Telehealth Resource Center. And today we are joined by Laura Hepp Kessel, who is the Executive Director of Telehealth Services at the SIU School of Medicine. And in her role there, she's responsible for managing SIU's telehealth activity. And I will let her introduce herself in a minute here. But today we're going to be talking a little bit about telehealth expansion and scaling and some of the challenges that go along with that. If you have a question during the webinar, feel free to put it in the chat. We'll also have time to take questions afterwards, so stick around for that. But without further ado, I will let Laura take it away. Thanks so much.
Thanks, Danielle. Happy to be here and appreciate the invite. As Danielle said, Laura Hepp Kessel, I have been working in our telehealth office and managing our telehealth activities at the SIU School of Medicine in Illinois since June of 19. So I had a little bit of time to get my feet planted and get some experience before the pandemic hit, but it's definitely been a wild ride over the last 3 years. So happy to be here today. I'm going to share some of information about our organization, about our telehealth program, and some of the challenges and opportunities due to the pandemic. I'm going to share my screen. Right. Danielle, I think, can you see that screen?
Yep, all good.
Perfect. Okay, thank you. Okay. So the SIU School of Medicine is a community medical school. If you're not aware of what that means, we don't own our own hospital. So most medical schools own their own hospital. We partner with a number of hospitals in our region to help provide that education that's needed and those placements for residency programs. We've been around since 1970, so a little over 50 years. We're located in Central Illinois primarily. Our first year students go to the Carbondale campus in Southern Illinois for a year, and then years 2 through 4 are at our Springfield campus. Our mission is to optimize the health of the people of Central and Southern Illinois through education, patient care, research, and service to the community. So those are our 4 pillars. We have 22 residency programs and 12 fellowships. We have 290 students who are pursuing a 4-year medical degree at any given time. I mentioned that our first year students from Carbondale and years 2 through 4 are in Springfield. We do have a new program that started a couple of years ago called our Lincoln Scholars Program, where those students spend all 4 years in Carbondale. So our curriculum is really focused on rural areas. And so adding that Lincoln Scholars Program where they spend all 4 years in Southern Illinois really, backs that up. 34% of our graduates are practicing in primary care, and we have approximately 429,000 patient visits to our clinics each year. Just to give you an idea, the centers and institutes that exist within our organization, we've got a neuroscience center, Simmons Cancer Institute, an Alzheimer's Research and Treatment Center. So we have our SIU Centers for Family Medicine, who have outlying clinics in many locations throughout Central and Southern Illinois. Fertility and IVF Center, our Institute for Plastic Surgery, Center for Clinical Research, Center for Human and Organizational Potential. We have a Center for Rural Health and Social Service Development, our Southern Illinois Trauma Center, Parkinson Center, Center for Maternal Fetal Medicine, Hand Therapy Center, Hernia Center, and Breast Center. So we really try to provide that very specialized care that's needed for our patients. So just to give you a little idea of the timeline of our telehealth program itself. So in 1995, we joined Ameritech to implement a telemedicine network. In 2001, we received a HRSA grant to expand that work. In 2002, we established a presence or partnership throughout the state to provide education. And we launched a regional teleburn network with one of our partners. 2009, we installed video and audio conference equipment at various partner locations, primarily for distance learning and for providers and other staff. 2017, we began providing maternal fetal medicine services to partner facilities. 2018, we began providing telepsych services to our Illinois Department of Corrections facilities. We're doing telepsych in 2 of those facilities currently. And in 2019, we reorganized the office to create the Office of Telehealth Services, which is what we're known as now. We all know what happened in 2020 with COVID-19, kind of changed everything. In 2022, we created the Stroke One Call program with Decatur Memorial Hospital, one of our partners. So let's speak the same language. So just wanted to provide a few definitions. So when I say something, you know what I'm referring to. So pre-pandemic is what I would consider prior to March 2020. An originating site, as many of you know, is the location of the patient, and a distant site would be the location of the healthcare provider. PHE is public health emergency. Traditional site-based telehealth. We use that's the term that we use when we're talking about the patient being located in an originating site and our provider being at a distant site. And that's what we were doing prior to the pandemic and continue to do. And then telehealth to the home or direct to consumer is what we had. That's the program we created and have expanded since the beginning of the pandemic. So the telehealth programs at SIU Medicine. So we have our traditional site-based telehealth program. As I said, we've been doing that for a decade or two. That's where the patient's located, as I said, at that originating site, and the provider's a distant site. As you know, those are Medicare terms. We primarily use that telehealth service is used for dermatology, endocrinology, more specifically diabetes management, rheumatology, pulmonology, infectious diseases, psychiatry, and maternal fetal medicine. So we have traditional site-based telehealth partners that access those different specialty services for their patients. Our telehealth to the home program, as you all know, where patients remain at home or their office, et cetera, that was created due to COVID-19 and the pandemic really forced that for us. We weren't doing that before. And we, our program grew by leaps and bounds overnight due to that. So for our traditional telehealth, this is a picture of one of our old carts. We've just recently upgraded them, but we build our own carts in-house, and then we lease those out to our partners. Some partners have their own carts, but if they don't, they can lease one from us to access those services. I see our traditional site-based telehealth as sort of the in-between of patients staying home and patients coming into our clinic to see the provider. There's a nurse or MA on site with the patient to do vital, stethoscope. We have otoscope, a dermatoscope. To me, that's really kind of the in-between. They can help be the hands and nose for the provider, but the provider obviously still can't put their hands on them if there's a specific exam needed. So we still think that this has a place in the telehealth and in healthcare services that are being offered, and we continue to do this. This is a list of some of our sites. And here's a map to show where our partner sites are throughout Southern and Central Illinois, and then the different specialty services that are accessed from each of those sites. So as you can see, some of those sites, Springfield sort of in the middle here, it's not marked, but kind of near Jacksonville, between Jacksonville and Decatur. And some of our patients maybe in Robinson or Beattyville, it would be a 2 or 3 hour drive for them to drive to Springfield. So we really are providing that access to them, and they may not have been able to have that access or be able to see that provider otherwise. So some of the challenges and opportunities with our telehealth program, especially because of the COVID-19 pandemic. So infrastructure obviously was one of the immediate needs that we had to pay attention to. When the pandemic hit in March 2020, I was asked to create this telehealth to the home program and try to roll it out in our clinics as fast as possible, because we wanted to make sure our patients had that access to care that was needed. I joke, but we are a medical school within a public university within state government, and there are a lot of steps involved, and things don't always move quickly. So we decided to use WebEx, which is what we already had a contract in place for video conferencing. So we decided to use that to start our telehealth to the home program, because the contracting and procurement process for another platform we knew would take too long, and we would miss the window, and the patients would miss the care they needed. So we went ahead and used WebEx to get started. We were lucky we had that in place, although WebEx isn't designed to be a telehealth platform, so there were some challenges with that. We've looked at a lot of other programs, and we're working on getting a more telehealth specific platform that is integrated with some of our other systems. But we did start with WebEx, and also use Doximity. Equipment was a huge need. Most of our providers had towers, computers at their desk, and did not have laptops, didn't have cameras, didn't have speakerphones. So we very quickly, like everyone else, had to try to procure all of that equipment that we did not have on hand. I apologize. Trying to get those cameras, those speakerphones, all of the things that are needed to provide telehealth. Second monitors so that the patient could be up on one screen and the EMR could be on the other screen. We tried to get those and get those installed for people as quickly as possible, and laptops as well, because some of our providers only had that computer at the office and some of them needed to work from home. Maybe they had COVID themselves or had a family member and they could still work, but they couldn't come in the office. So we really were trying to procure that equipment like everyone else was at the same time, so that we didn't miss anything, and make sure it was installed and people knew how to use it. Education obviously was a big challenge and opportunity for us. We had to educate, everyone involved, our patients, our providers, our staff. Our patients, many of them had not used telehealth before, and definitely not the telehealth to the home that we were trying to get them to use for the first time. We tried to have conversations with them as staff time allowed, to try to walk through, maybe do a test with them on the system before their first appointment. We created patient documents that explained how to use the system and had pictures and step-by-step on how to download the software and how to use it and how to log in. We had to get those obviously to the patients via email. So we really had to think about how we could educate patients virtually, or mail them something if needed. But that was definitely a big focus at the beginning on how to make sure to get that information out and make sure the patients had the information they needed to be able to access the care. We had to educate our providers because they hadn't been doing this before. Again, some providers had been doing our traditional site-based telehealth, so they've been doing some telehealth, but no one had been doing the telehealth to the home. So we had to figure out how to educate the providers. We kind of did a train the trainer model, where we went in and we would try to train a couple providers and maybe a couple of the administrators or staff, and then go on to the next clinic and leave them behind to train the others. So that's how we thought we could cover ground as quickly as possible by doing that train the trainer model. We also had to train staff, how to support the providers for the visits. We had to make sure they understood the different services that we offered. Some of them didn't even know we did telehealth at all because they weren't in an area that was using that. And then we had to make sure they knew what kind of patients made sense for telehealth, who could be scheduled. We created all kinds of handouts and information to try to share, to try to explain the different telehealth services offered and how to schedule those, etc. We had to create new workflows and processes. So not only did they have to schedule the visit in our PMS system, but then they also had to go in and schedule the telehealth visit in the platform. So that was an extra step. It took extra people to be able to do that, but we had to make sure that was done. We had to make sure the patient information got out to them before the visit. And again, if staff time allowed, then they also would follow up with the patient to try to do a test with them, make sure they had tested the equipment, and they were going to hopefully be able to successfully connect with the provider. Communication was a big piece of all of this. I feel like communication is probably the most important piece. Yes, we have to have the equipment, but without communicating and being able to get the information out correctly. So when we disseminate information internally, we focused on sending things out via email, especially to our providers. Our intranet, we have an intranet system. We would try to place things on there. We have started holding town halls, virtual town halls, where we share information about telehealth, things that have changed, things to note. Just make sure that gives people an opportunity to ask questions and for us to share information. We create one-pagers, diagrams, charts, anything that would make it easier for someone to reference this and say, to make their lives easier and make it easier in scheduling things. We also created videos trying to explain how to use the platform or how to use, how to schedule visits, etc. So we really tried to look at any way that we could to get information out and allow our providers and staff to be able to absorb that learn from that, and we could continue on. Again, for patients, we would use email a lot to get those patient instructions out. We also would place information on our website and then use social media some as well to try to get that information. One of the biggest communication barriers we ran into throughout this is that how to manage and respond to information from professional organizations. So sometimes professional organizations, the Academy of, et cetera, whatever it is, whatever professional organization our providers may belong to, they may send information out about things they're advocating for or things that they think need changed, but it may not always be clear that it's something they're advocating for versus something that's actually in place. And then you have a lot of confusion because providers or staff or whoever reads that thinks that that's something that has happened or that is new, and maybe it's just something that they're trying to advocate for change. So I feel like we've had to continuously, especially with our Office of Compliance, respond to that and manage that to try to make sure that what is actually in place and the rules that are in place right now is what's getting out there. And then when we sometimes see emails that are being sent around that say something maybe that isn't quite right, we have a chance to go back and try to explain that and educate on that. So I think that communication piece has been important throughout. To give you an idea of our reach in Illinois, so when a lot of people think of SIU School of Medicine, think of us being in Central and Southern Illinois, and those are our primary areas that we serve. But using telehealth, we're able to serve a lot more patients and provide the access that they wouldn't have had otherwise. So the map doesn't exactly match this, but we have, in the first year and a half or so of the pandemic, we saw patients in 99 of 102 Illinois counties. So I just think that this is such a good point to make, that, a lot of people think, in Cook County up in the top part of the state, Chicago has a lot of access. There are a lot of providers there, and there's patients. There are a lot of patients seen there, but that doesn't mean that patients aren't still looking for providers and need access. And telehealth is a way to get past that barrier and offer additional options. So again, our expansion. So just to give you an idea, prior to the pandemic, we conducted just under 2,000 telehealth visits in calendar year 19. If we look at the first year of the pandemic, it was more than 77,000 telehealth visits. So we grew overnight. In May of 2020, we had a stay-at-home order in our state, and we peaked at about 11,500 telehealth visits that month. We have not been that high since that month. We're averaging around 3,500 to 4,000 telehealth visits a month right now, but we're still doing almost twice as much in 1 month as what we did in 1 year prior to the pandemic. So this obviously is here to stay. People like using it. It works well in some situations, and we want to continue down that path. This just shows, again, our telehealth visits by year. So you can see there in 2019 where we had just under 2,000. And then obviously we've gone down by about 10,000 each year since we started there in 2020 with the pandemic, but we're continuing to do a lot. And then this just shows again by month for the years of how many visits. And as I mentioned before, you can see there in May of 2020, it really, really peaked. And I think that, if you think about the different stages of COVID and when things have peaked in COVID, you can kind of see where those numbers went up and down based on when COVID was bad and we were trying to keep people out of the clinic. So the future of telehealth at SIU. So we're trying, as I mentioned, we're trying to secure a telehealth specific platform that we can use in the future. Right now, we have about 4 different platforms that are being used, depending on if it's telehealth to the home or our traditional site-based telehealth. We're hoping to get that number down to 1 or 2 with a new platform that's more user-friendly for patients, providers, and staff. Device agnostic, we want it to be web-based. We want there to be a technology test in advance so the patients have an opportunity to test their equipment to make sure it works before they try to get into the visit and have trouble. We want the ability for patients to complete forms, patient tech support provided if there are issues, and we want appointment reminders, texts, and emails to be sent out. Some of this is very common now and it's happening already, but these are all things that were important to us as we looked at a new platform. We're going to make sure we have a patient satisfaction survey built in so we can get that feedback, especially that's specific to the telehealth visits. Virtual waiting room. It seems like sometimes patients, if they're in the clinic and they're sitting in a clinic room waiting on the provider and the provider's running late, they're not likely to go anywhere. But when they're in a telehealth visit, they may think they're in the wrong place, or they may just think that it's not, maybe they had the date and time mixed up and they may log out. So we feel like that virtual waiting room helps kind of pass time and keeps them busy as they're waiting for the provider if they are running late or if they're just logged in early. And we do, as I mentioned, we think that there is still a place for a traditional site-based telehealth program, and we'll continue to do that. And we also want to continue our telehealth to the home program, but we need some permanent telehealth reimbursement changes made, especially at the federal level, for us to continue to do that. Moving forward, things to note, we need to incorporate telehealth into our regular practice. It no longer needs to be a feature. It should just be one of the ways that we provide service and healthcare to our patients. We need to think about block scheduling, I think, for telehealth. It seems to work better than trying to intermingle these telehealth visits in with the in-person clinics. Think about which patients that are ideal for telehealth. Really, I think all of practices, and ours included, need to think about that and set that up for success. We're really trying to move from a crisis mode to a new normal. I think the pandemic's behind us, it seems, and we need to be thinking about what this looks like going forward and not just in that kind of crisis. We'll continue to advocate for payment parity and other related reimbursement changes. In Illinois, we've made some great progress in that. But at the federal level, CMS has made some extensions permanent and then some extensions through the end of this year, the end of 2024. We really need to keep an eye on that and make sure that telehealth can continue in the future and that we can get paid for providing those services. We're really focused on patient engagement. So we are focused on creating some patient engagement videos. A lot of these are 80% of probably what's included in these videos applies to patients, whether they're doing a telehealth visit or an in-person visit. But we make sure and include that telehealth spin on it as well. But just talking to patients about how to be prepared for a visit and what to do to be ready, how to treat the visit the same as if it was in person, have your questions ready. Again, a lot of things that it's just things that normally would apply for any kind of healthcare visit, but we're trying to focus on the telehealth piece. And then provider education at all levels. So we are also working on some CME online modules where providers can get that educational units that they need and that for their licenses. And we want to do some core competencies. We're working on that, how to do a physical exam during a telehealth visit, for example. And then we're going to have smaller, shorter videos that are specific to maybe skincare or behavioral health or physical therapy. And we want providers, again, to anywhere, not just from SIU, but to go in there and be able to pick and choose what makes sense and what would benefit from them and be able to participate in that. So we're working on those educational videos. And we'll continue to plan as much as possible without knowing what will be paid for long term. I want to go ahead and plug, we're having our second annual telehealth conference in Illinois on Wednesday, August 30th this year. It will be hybrid in person in Springfield, Illinois, and there's a virtual option. We do not have registration open yet, but it should be in the next month or so, I would say. So if you're interested, please reach out, or you can go to our website, and again, it'll be up in the near future. Happy to answer any questions.
And if you have questions, you can go ahead and put those in the chat or take yourself off mute. It really doesn't matter. Something I was wondering about, you talked a lot about how you're using a couple different systems for telehealth right now. Is that something where interoperability between those systems is a challenge for you?
Yes, definitely. Yeah, so none of the systems we're using right now are integrated into any, like our EMR. We have a separate, I think it's PMS, stands for Practice Management System, where we do all the scheduling and where our consent forms are logged and things like that. And then our EMR is separate from that. None of those systems connect to either of those, which makes it difficult. So it's really, they're kind of working in silos. They get in here to get this information and they log in here. Whether they're doing a telehealth to the home visit, they have two options and they can use whichever one they would like. But then that's coordination with staff on which ones they're using, because staff are involved in one and they don't need to be involved in the other. If they're doing traditional site-based telehealth, it's primarily one or two that they're using and they know and it's consistent. So that definitely is a challenge, and that's why we're looking forward to our new platform that will be integrated into our PMS system, as well as our TouchWorks EMR system, and that will make life easier for everyone involved.
Yeah, I know that cutting down on sort of having to do duplicate effort where you have information from one system, you have to input it into another.
Yes.
That is a huge challenge for folks who are doing telehealth a lot of the time.
Definitely.
Mhm.
I keep saying, if they fill out a form and we have to input it into our EMR, I guess it's no different than if they were in the office and doing that, but it would be so much easier if it just automatically flowed in and went into the section it needed to with that discrete data, and no one had to manually do that.
Yeah, when the systems talk to each other, it can be a great advantage of telehealth, but when they don't, it can be a huge hassle.
Definitely.
And something that if you could go into further detail about, I would appreciate. You talked about doing block scheduling. Could you talk a little bit about what that means?
Sure. So, we have some providers that will just they have a half-day clinic, for example, and they'll just do, 4 in-person patients, and then they'll do a telehealth visit, and then they'll do inpatient or in-person. That works for some, but what a lot of feedback I get is that either they forget about the telehealth visits in between, they lose track because they're just going physically from room to room, or they're running late because of the in-person visits. And then by the time they log in for the telehealth visit, the telehealth patient has already given up and logged off. So it works for some people, but it seems like a lot of our providers, they don't like that setup. So what we've tried to start doing is, if they're doing a lot of telehealth, we're encouraging them to set aside a half-day clinic a week. So they just have telehealth, back-to-back telehealth. That's what their clinic is. It also can help with space as well, depending on what staff may or may not be helping them with a telehealth clinic. They may be able to do that from their office and not actually take up space in the clinic as well. And for others that do telehealth, but maybe not enough to have a whole half-day clinic set aside, we're suggesting they do maybe the first 4 or 8 visits of the morning, or their afternoon clinic, or even the end of the clinic, either the end of the morning or end of the afternoon, so that those are all together, so they can get through their in-person appointments and then end with just all telehealth back to back, or they can start the day with telehealth and then move into their in-person clinic. It also helps, we have some providers that they like at the end of the day doing some telehealth visits when they don't necessarily need staff to back them or on that, and they can see more patients without keeping staff in the clinic later than when they normally would be or plan. So we're trying to we have some providers that have figured that out and doing that, and we're trying to encourage others to try to do that block scheduling for telehealth instead of trying to just intertwine it in their regular schedule.
Right, and I would assume that the trade-off you get there is that patients have a little bit less flexibility when it comes to their own scheduling.
Yes. Mm-hmm.
We have something in the chat, so let me check that out. Oh yeah, so it's block scheduling has also been identified as a best practice and positive practice from our providers as well, and is being used sporadically in an organization. That's from Henry Ford Health in Detroit. So it's good to hear that that's something that's going to be, or that is being successfully implemented, because despite the drawback of having patients have a little bit less freedom, I'm sure that's a lot easier for providers. Yeah. I can't imagine going from an in-person appointment and then going to the computer and back. And like, that sounds like a huge hassle.
Yeah. Just we did a provider survey getting feedback on telehealth in the last month or so, and they talk about that. Like, I just move from room to room, and sometimes I miss an appointment because I forget there's a telehealth visit in the middle or something. To your point, it doesn't maybe provide as many options for the patient, but but we want to make sure they're seen and not overlooked, or they wait longer, because it's easier to get distracted when you're in the in-person clinic than if you're doing telehealth. So yeah, I've had a couple providers that say that they don't prefer the block scheduling, but I would say overall it does seem to work better for most.
It's good to hear. And it's good to hear that you're doing surveys to sort of see where providers' feelings are in the different aspects of telehealth, not just do you like it or do you not, but how do you feel about all of these different aspects?
Yes, definitely. We've got feedback on if they had needs, what kind of educational offerings they would like, what was working well, where was there opportunity for improvement. We really tried to, we did that the first few months of the pandemic and had a good response, and that helped us kind of develop plans. And then we did it again, like I said, the last couple of months. So we're trying to do that. We probably need to just do it annually, but during the pandemic, we lose track of time, feel like it was just, but we really want to do that, and we want to improve things, and we want our providers to want to offer telehealth. So we want to try to make things as easy as possible for them. And obviously, if the provider's happier and it's easier for the provider, it's probably going to be easier for the patient as well. And we have to focus on the patient side too, to make sure that how they're logging in and how they're accessing the appointment is easy. So we're trying to make improvements from every avenue and constantly tweaking things.
Right. And that's great for constant improvements. Love that.
Mhm.
So I will let you go in a minute because I know you got a bit of a sore throat today, but one more question I wanted to ask. So you talked a little bit about the normalization of telehealth and that you're trying to integrate that into your existing systems. So how do you think, what is the best way to do that? Like, how do we integrate telehealth and normalize it as part of our existing practices?
Well, I think it's easier said than done. It goes back to education, I think, because patients are interacting with, our front office staff, they're interacting with the call center, they're interacting with the nursing staff, all of those people before they even get to the provider.
Mm-hmm.
So there are those that's those many levels where the patient's interacting with us, that telehealth can be offered in a positive way, and not like, well, we can't see you in person, I'm sorry, but like the second best option, here's a telehealth visit. So I think it's really trying to make sure that everyone's educated, that in some situations, telehealth is as good or sometimes better than in person, depending on what you're being seen for. But that education is really important, and it's hard to get that out to everyone and make sure everyone is saying the same thing and understands it. I feel like that's one part of it. We just really have to educate and make sure. I field calls occasionally where someone will say, we're not doing telehealth, or we don't do that anymore. And so then I have to go back and figure out which department that was and make sure we're educating staff. I think that, staff have so many things coming at them all the time. It's hard for them to keep track of all the different pieces. But if we're giving mixed messages, that's not helpful. So I think that that's a big piece of it, making sure everyone's on the same page and educated. And we tried to put a list together. We went division by division within the departments and had them put a list together of ideal use cases for telehealth. Mm-hmm. Because some providers are more comfortable than others. And we were hoping that would give our providers the rest of the providers in my division think that these are ideal for telehealth. I haven't tried that yet. Let me try that and see if I think it works okay. So we tried to put those kind of lists together as well. And just, I think it's we're continuously be working on that and trying to get information out and get feedback and make sure everyone is on the same page.
Yeah, no, that sounds like a good way to go about doing it. So we have one more question from the chat. So are you doing anything to tackle the digital divide or telehealth literacy in your patients? And that goes along with the education a little bit, I feel.
Yeah. So I mentioned we're doing these patient engagement videos. We have, I think, 8 that we've sort of lined out, and we have staff that are working on scripts for those. We're really focused on trying to do both we want to make those so that they're not all the same and don't look the same. So some of them are going to be more of scripts and acting out and, simulated patients. Some will be more of like a Q&A between maybe a provider and a staff person or someone. So we're trying to do some of that to try to help patients better understand what they're doing, what to expect. I know a lot more people understand today than they did before, but there's still a lot of people aren't sure or they're uneasy. So we want to try to share that information and make things easier for them. One program we're working on, I serve on the Governor's Rural Affairs Council in the state. Our lieutenant governor chairs that. and I'm the Health and Healthcare Committee Chair. So we're doing a pilot project. We're getting ready to start working on the contracts right now, where we're going to set up equipment in a Farm Bureau office and in the University of Illinois Extension office, where patients can go there and do their telepsych appointments. So it's just a pilot. It's only 2 sites to get started. But we want the patients, like if they live out in the country and maybe just don't have a good connection, or maybe they're out of minutes on their phone, they don't have data, or for whatever reason, they want to do a telehealth visit, but there's individual circumstances, or maybe they don't have a private place in there where they live. Maybe they live with a lot of people or whatever. We want them to have that space to go to in their community. It's not going to be in a healthcare facility. Won't be obvious they're going to the psychiatrist's office or whatever, that they can go, they can utilize that equipment we have set up and access that visit, and they don't have to make the drive. They may drive into town potentially if they live outside of town or whatever, but they don't have to drive the hour and a half maybe to our office. So we're trying to, that's one thing we're doing as a pilot project that will be started soon. And we're hoping we can kind of get some feedback on that and get some results and see if it works well.
No, that sounds like an awesome project, and I'm excited to see where it goes.
Yeah.
So one more question from the chat here. Jessica Coleman asked, do you do phone only? So do you do audio only care at all?
So we do it more than I wish we didn't do it as much as sometimes we do. How about that? I think that sometimes it's the comfortable way to do it, but it doesn't provide as good of care as we could with the video. So obviously for behavioral health and things, that probably makes perfect sense, and the video doesn't add as much. But for some of our other specialty visits, we're really trying to encourage we don't do audio only unless it's absolutely necessary. So the provider talking to the patient is, I'm sure, still better than not having any communication. But we really want, we're really trying to push that video visit in almost all situations and get away from audio only.
And I know that's something that gets complicated with reimbursement as well. Yes,
definitely. And that's what we also are saying, like, you may not get paid for this after the public health emergency is over, depending on who the payer is and whatnot. So that's one of the ways we're encouraging providers to not do audio only.
Yeah, because I know it can be a good option for folks who really don't have the connection, like folks in rural areas. But if you are able to get on the internet and do like a video chat, like a lot of the time it adds another dimension that can be really useful.
Definitely. Yes. Yep.
All right. Well, I'm not seeing any more questions. So thank you all for joining us today. I really appreciate you coming on, chatting with us about this. This webinar will be on our YouTube channel. So if you want to go back and view it, you can feel free to do that. We also will be posting those slides and sending those out to attendees. So feel free to reach out with any additional questions and concerns. Well, Laura, thank you so much.
Yes. And I apologize for the coughing, but glad to be here today.
You are totally fine. Thanks so much. Goodbye, everybody.